This presentation because I think some questions have come up about recent trends in some of the newer illicit drugs or ones that surface from time to time that people might want to familiarize themselves with. So I'll be talking about these substances. In fact, we'll just go to the next slide so you can see which ones I am going to talk about. There were a couple of questions. One was about bath salts and another one about nutmeg, of all things. But I did add two others that will come up in conversations with patients or counselors or other medical staff, and that's salvia, not saliva, but salvia, and the synthetic cannabinoids. And these have been in the press recently, and overall, these are relatively minor problems in terms of drug use in the country, in the world. Certainly they could become a serious problem for an individual, but it's still tobacco, alcohol, opiates, stimulants, and cocaine that remain the main problems, and cannabis, the botanical kind, not the synthetic kind. After I've done reviewing the four substances that are listed there, we'll talk about some of the recovery medications that are being used. You know, the exciting part of being in addiction medicine now is we now actually have some medications that actually work. It used to be just antabuse and really nothing else, but now we have several. And I'm going to talk about the four that I use the most frequently. There are a few others, but the ones that come up the most often are, at least here at Rogers, will be buprenorphine, which is more commonly known as Suboxone, naltrexone, which comes in two forms, a tablet or the injectable variety, with one of the trade names being Vivitrol, that being the injectable naltrexone, acamprosate, also called Camprol, and I'll just go over antabuse, also known as disulfiram, since there is still some clinical utilization of that medication, and I'll kind of go over how you use it. All right, so onward. This is two pictures of salvia. The name of the plant is actually Salvia divornum. It looks a little bit like the mint plant. It grows in the southern parts of Mexico, Central America, South America. I don't know if you can just go out into the woods and pick it any time, or you have to cultivate it, how common it actually is. But people will ingest it for its psychoactive effects. They can chew on the fresh leaves. They can make a tea out of it. They can dry it and try and smoke it. The actual drug in the plant material is called salvinorin A. And salvinorin A is the psychoactive substance. And it probably works at a type of opiate receptor named after the Greek letter kappa. And we don't really know as much about the kappa opiate receptors as we do about the mu opiate receptors. The mu opiate receptors are the ones that we think of in terms of the clinical effects of opiates such as morphine for pain control or heroin to get high. But individuals will ingest the substance to get high, and the high is a little bit different than you might expect from other substances. I think people attracted to salvia are those who use cannabis on a regular basis. There's some similarity to it, and they're probably experimenting with it to see what it's like. In terms of its legal status, the DEA have put it on a watch list, but it is not a scheduled or a banned substance at the federal level. Certain states have made it illegal. Wisconsin has made it illegal, but the way they wrote the laws, it's kind of murky in that salvinorin A itself, the actual chemical, is what's illegal. They don't really talk about the actual plant material being illegal. So that kind of like, can you still sell it or not? I'm not sure. It's kind of open to interpretation of the law. Well, what does it do? It has a somewhat intense onset, lasts only a minute. The duration of the intoxication is not that long, probably about 30 minutes or so. People will have a sense of well-being, or they hope to get a sense of well-being. They may have some visual perceptual changes, and they have a sort of sense of detachment. Maybe they just kind of sit there when they're intoxicated, staring out the window, sort of not responding to much stimulus. Of course, there can be a downside to the intoxication as well. People can sometimes respond with panic and fear, dizziness, loss of coordination, slurred speech, and sometimes uncontrollable laughter. So there may be patients who show up in the emergency room under the influence of the substance, and of course, since it's a relatively short duration of the intoxication, they probably just improve in the emergency room. There's no antidotes. I'm not hearing of people having highly agitated behavior where they become dangerously aggressive or do any of the strange things that have been attributable to some of the other substances that I'm going to talk about today. So it's sort of out there.
Is it ingested or smoked?
People will try and smoke it, make a tea out of it, chew on the leaves.
Okay.
So I think those are the ways that people are using it. I'm not coming across anyone who's using it on a regular basis, but I think with our adolescents, younger adults, you might want to ask about it, or if they mention it, you know, you should kind of have an idea that this is a substance that can have some problems for the individual.
Did you consider the street name?
The street names, yes, but I have to look at my notes. I haven't memorized them. Sally D, Magic Mint, Shepherdess's Herb. How's that? Sally D would be for Diburnum, which is the species name. There's other types of salvia. If you go to your garden center in the spring, you can probably put some in your garden. But those would be the ones about the psychoactive chemicals in them.
Could you repeat those one more time?
You bet.
Sally D.
Shepherdess herb. Shepherdess as in shepherd. All right. So what we've been seeing in the press lately is a lot of talk about some of these new synthetic drugs, specifically the synthetic cannabinoids. These would be chemicals that have cannabis-type effect, but come from the laboratory as opposed to from botanical or plant cannabis, as well as a type of designer drugs that are sort of more commonly known as bath salts, since those who are selling them give the product a false name to sort of circumvent the legal system. And not only bath salts, but sometimes jewelry cleaner, plant fertilizer. There's probably other ones, but it contains powder, which is probably contains psychoactive substances that are designed chemicals, meaning they come from clandestine laboratories in this country or from legal laboratories in other countries where they have less oversight into such things. Typically, what they're trying to do is try and circumvent the laws by changing a molecule so that it's no longer illegal since its chemical structure has changed, and subsequently then can sell it without getting in trouble for trying to sell a banned substance. There's two classes which I've kind of mentioned that have kind of come to our attention is the synthetic cannabinoids. They go by their trade names, K2, which is the name of a mountain in the Himalayas, or Spice, sometimes marketed as fake weed or legal marijuana. They're no longer legal, they're now banned. They're Scheduled I substances. The other ones, the bath salts, are actually, you know, when we're putting this information in formal medical record, we should call them substituted cathinones, or at least cathinones. Think of cathinones as amphetamines. They just have a different chemical structure than the amphetamines, but they have a similar effect. But basically by designing these substances, you're trying to come up with a substance that has an effect like a stimulant, possibly as a hallucinogen. Is everything okay?
No, it's good.
Okay.
Sign in and hand out.
Or what we call like an empathogen. You know, you think of ecstasy, time of having these types of effect where people have this intense sort of, from the intoxication, this intense empathy or love for other individuals that is brought on by the substances. You know, people will take ecstasy. I think at one time ecstasy was used as a tool in psychotherapy, but that proved not to be helpful.
Did you say these are now illegal?
Yes.
Okay.
Yeah. So this is a picture of synthetic cannabinoids. This is spice. Basically, it's some sort of plant material, which you probably are not going to be able to easily identify, sprayed with the chemical, the psychoactive cannabinoid on top of it. You are not going to be told on the packet exactly what you're getting, though. So there's no guarantee, even though you might think you're using a synthetic cannabinoids, there's no actual guarantee that it really is that. So that can be a problem in that the user is not using something that they're familiar with. Synthetic cannabinoids are different than the cannabinoids that you get in plant marijuana. And the big difference is that the most potent cannabinoid in plant marijuana is THC, delta-9 tetrahydrocannabinol. There's other cannabinoids in plant cannabis which are active, but the most active one that has the most effect on humans is THC. Actually, THC is only a partial agonist on our cannabinoid receptors in our head. So by partial, meaning if those receptors are like switches, THC only switches them on partially. Like if it's a dimmer switch for your light, it's only turning the dimmer switch on halfway, while the synthetic cannabinoids switch the dimmer switch up to full. So they have a different effect than the botanical cannabinoids do. And there are literally hundreds of them. And they've all been developed in laboratories for research purposes. They have names typically beginning with JWH, which is a researcher's name. I think it's John W. Hoffman. AM, I can't remember. HU is Hebrew University. CP has got something to do with Clemson University from the South. So it's the name or the place where they were initially designed for legitimate research purposes. These people who were designing them were looking at how these chemicals, work on animals or whatnot, or looking at them for pharmaceutical purposes. But the secret of their manufacture obviously escaped, and now they're manufactured in clandestine laboratories or in laboratories in other countries where there's no oversight. There's literally hundreds of them. But the ones that we see the most, or at least the ones that are recorded the most often, are the ones at the bottom of the slide there, JWH-018, and then you can see the names of the other ones there. So what's interesting about the synthetic cannabinoids is that your urine drug test for cannabis, we're looking for THC or something from the plant. We're not going to identify synthetic cannabinoid on your routine urine drug screen. So it will come up negative. So some people are using the synthetic cannabinoids to get around urine drug testing, or at least you're not going to identify them. And the problem is, when you do want to identify them, you have to ask for an individual test for each type of these synthetic cannabinoids. So literally, if there's hundreds of them, you got to get the right ones to identify use. But hopefully, there's a good chance that they're probably using the top 5 that are in vogue. But that's subject to change, and the companies like Millennium that we use, at least in PHP chemical dependency, hopefully are staying on top of which ones to be looking for in the region and in the country. So you avoid detection on drug screens. Intoxication, well, the individual is looking for a cannabis type of intoxication, a sense of decreased anxiety, changes in perception of time, changes in appetite, looking for a sensation of well-being. At least that's the hope from what they're trying to get from the intoxication. But sometimes, and you don't typically see this with normal cannabis intoxication, but patients can become quite psychotic. Seizures have been reported. Patients highly agitated, ending up in the emergency room, requiring emergency treatment. People have even become unresponsive and just not responding to any type of stimulus until the intoxication has passed. So typically, habitual cannabis users don't like them. If you listen to how they compare, they'll kind of say, yeah, I kind of liked it, but I'm going back to the real stuff. But I think people who do use them more habitually are those probably in jobs where they're subject to routine urine drug testing, or if they're seeing us and we're testing them and they want to keep smoking, they might try something like this.
I read something from a transportation council that actually said that truck drivers are using them because it avoids the drug screening.
Yeah, so you avoid.
They have to do routinely.
Right, so occupational drug testing, people in sensitive positions, truck drivers, airline pilots, prison guards might be using this to avoid detection of botanical cannabis.
These
So the question is, do these have the same addiction potential as botanical cannabis? Botanical cannabis probably has an addiction potential of about 9 to 10% in users. I am not aware if there's a higher or different addiction potential. I don't think we have that information at this point. I would say there is an addiction potential, though. In terms of what's going on in the country with the use of these substances, they are now banned. There was emergency legislature in the first part of 2011, followed by permanent legislature in the summer of 2012, banning these substances. So they are now Schedule I substances. So they are illegal. So hopefully they've been taken off the shelves in places where they would be sold, head shops or convenience stores, which don't discriminate that much as to what they're giving their consumers. But probably people can still go to the internet to purchase this. And internet sales, it's very hard for law enforcement to do much about, unfortunately. Use might be going down. I looked at the American Poison Control Center, who get all the information from the state's poison control centers, and they kind of calibrate all the data. And the peak was in 2011. Now in 2012, there were less calls. And if you look at the year, month-to-month graph, which I don't have, in 2012, it was going down January through December. So it may be that with the becoming less available through the scheduling, we might not be seeing as much, and it'll probably hit some plateau and then be a kind of a background drug that you need to be aware of.
I think, too, part of this has been marijuana laws loosening in some states.
Yes.
We're starting to see the reflection of that also.
Yeah, that's a good point. Yeah, I didn't think of that.
You just can smoke Miracle-Gro? Is that really true? That's what the patient told me, that K2 is really just Miracle-Gro.
No, it's not a nitrogen-based plant fertilizer, but it can be marketed as a plant fertilizer to kind of disguise what it really is. Monitoring the Future looks at drug use in 8th, 10th, and 12th graders. They do a twice-a-year survey. They did not start asking about synthetic cannabinoids until 2011, and then they only started asking the 12th graders in 2011, but about 11.4% of 12th graders that they surveyed had indicated that they had used it within that year, compared to 36% who had used botanical cannabis. I just threw inhalants in there, just because that's another first drug, but a lot of youngsters will use based on availability in the household. It stayed about the same in 2012 for 12th graders, and then they did also ask 10th and 8th graders, and they reported too that they had been using it as well, but at lower amounts. For 8th graders, it was 4.4%, and 10th graders, 8.8%. So the youngsters are getting into it. They did try it, and we'll have to see if they continue to use these products. Okay. Now we'll move on to bath salts, which are really meant to be called substituted cathinones. Naturally occurring cathinone comes from a plant called khat. I've also heard this pronounced khat. It's a plant that's grown in the southern part of the Arabian Peninsula, also the Horn of Africa. So sometimes you'll see this substance being used in areas in the U.S. where there's a lot of people from those areas. I think there's a lot of people from Ethiopia in Minneapolis, and they've had some trouble with khat there. The product's usually chewed, I think, or they make a tea out of it. It does start to lose its potency with time, so I think they try to have fresh khat. Otherwise, you can't keep it for too long. It does lose its potency. We don't see it very often. It's not something I really screen for. However, bath salts are when you take a cathinone molecule and you adjust it somehow, and it has a different effect. The thing is, when you actually buy bath salts for psychoactive purposes, as opposed to bath salts to help the cleaning process in the bathtub, you can get a lot of different things. And this information is from Arkansas, where they had a designer drug consortium that intercepted about 200 different brands. And they came up with all these different things coming up. Some of these are not psychoactive. Lobenosol, for instance, is a veterinarian medicine that is used, I think, to treat some sort of parasite, but it can cause neutropenia in humans, where your bone marrow stops making white cells, which could be a problem for you. Sometimes they're synthetic cannabinoids when you thought you were using a designer drug like substituted cathinone. The ones, however, that we're thinking about in terms of substituted cathinone are on the sort of upper left hand of the wheel, and that's methadrone, MDPV, and methylone. MDPV is the one that seems to be popping up the most in samples that are analyzed, probably about 70%. While if you go to Europe, bath salts there tend to be methadrone. But sometimes they have dextrose in them, which you're not going to get intoxicated from. That's just a sugar. The American Poison Control Center, of course, saw a big jump in bath salt intoxication, poisoning calls. It really went up from 2010 to 2011. But already in 2012, we've seen a decrease in calls regarding these substances. And again, like with the synthetic cannabinoids, if you look at the month-to-month data for 2012, the graph was going down from January to December. So perhaps this problem is starting to subside and we'll just hit some plateau. These are real bath salts. You put them in your bathtub. You don't ingest them typically. And if you did, they wouldn't make you high. This is the type of product that you would buy to get high. And some tip-offs that you're buying something that's illegal is that it will say on the packet, not for human ingestion, not for anyone 18 years or older. Oh, you know, this one has novelty written on it. It looks a little suspicious to me, at least, but I'm sort of a discerning person. But the thing is about it is there's no instructions on how much to take. So if you're not an experienced user, you could take a really large dose of the stuff if it does contain something like MDPV. You're probably wanting to administer about 5 to 15 milligrams of MDPV to get the intoxication. But this whole package contains maybe as much as 500 milligrams of MDPV. So if you're not careful on how much you take, you could take a really super therapeutic dose, so to speak, that could really lead to a problematic intoxication. But even at the safe levels, it's a problem.
How
Yeah.
inflamed might it be, say, to turn my friends or neighbors into having,
Well, that's the problem. You can see a lot of psychiatric side effects from this medication. I'll get right into that. Here's the kind of the long names. MTV is really methylene dioxypyrovalerone, so we'll write that in our notes. But that's where these names come from. They're kind of complicated. So what they're hoping to get is to kind of get a rush and a buzz and a high with supposedly no hangover, make you maybe more sociable. Some doubt there. More energy, sense of well-being. Somehow people might think that they're going to study better. You know, students might think they'll study better on this, as they do think with the amphetamines, you know, when they're passing their Ritalin and methylphenidate and amphetamines around to improve their studying. Maybe they think the same way with the cathinones. You can get these tested for on urine drug tests, but you're going to have to request it. We can request it on the Millennium drug tests, but it's not going to be on routine drug tests. Cathinones might come up positive on amphetamine tests, but that is not a reliable way to be looking specifically for cathinones. So a lot of medical adverse effects, which you can kind of read, a lot of stimulant-like issues that could lead to a myocardial infarction, seizures. They'll grind their teeth like people do on ecstasy. So these are some of the types of things that you'll see with the medical adverse consequences. Psychiatric adverse consequences, like Bill was asking, are this. You know, people can really have some significant mental status changes where they can become quite dangerous. There's been some news stories of some just horrible behavior where people have been intoxicated on these substances, and you know, police have even had to use lethal force, I think, on some individuals. There's some concerns that this could lead to sort of a medically induced Parkinson's disease. There have been other designer drugs when people were trying to synthesize meperidine, which is also known as Demerol, back in the 70s. And unfortunately, when they administered it to themselves, it all ended up with Parkinson's disease. So we have the same kind of concerns now. So very dangerous intoxication. There's no antidote. It would just be supportive fluids and sedating individuals, probably with benzodiazepines, perhaps with antipsychotics. This would be in the emergency room. Okay, nutmeg, mace. So this is a spice from the South Seas. The nutmeg is the brown nut in the middle. The mace is that red stuff on the surface of the nut. So you get two spices from one source, but both are psychoactive if you take enough of it. I think this has been known for hundreds of years, but occasionally someone will try it. Nutmeg contains an agent called myristicin, which probably is an anticholinergic, such as atropine. Other types of substances that people misuse that have anticholinergic activity are the sedating antihistamines like Benadryl, hydroxyzine, diphenhydramine. So when you think of anticholinergic intoxication, everything dries up. You know, your mouth gets dry, your eyes get dry. You kind of get a strange sense of intoxication. How much? Well, probably enough in your household. Those containers the stuff comes in, which are about an ounce, probably if you ingested the whole thing, you'd get the intoxication. At least 7 grams. So there's 28 grams in an ounce, so you guys can kind of do the math. Other sources said 1 to 3 tablespoons. I think it's an unpleasant intoxication. People get delirious with hallucinations, they dissociate. I think they just ingest it orally. I guess you could, people will try anything, so maybe nasal inhalation. You're not going to get this from using nutmeg appropriately for culinary purposes.
No, but I heard of someone a kid putting it in oatmeal, McDonald's oatmeal, dumping 3 tablespoons. They had it all figured out, and sure enough, I mean, he was psychotic.
Yeah. So there are about 67 cases called into the U.S. Poison Control Centers. I think it's just one of those things that's going to be in the background. Bored teenagers or people who are into trying novel substances or novel to them will try it, and it will kind of come up from time to time.
You have to kind of put up with the noise before you get into the high.
What now?
You have to put up with the noise before you get to the high.
What does that mean?
Well, all the other crap that's going on within the body
Yeah.
system,
Yeah.
drying up. So before you ever get any stimulation out of it, you have to go through all that stuff first. So I think once people try it, they go, I don't know if I want to do that again.
Yeah. But it's just one of those things that just points out that there are intoxicants in the house that you might not think of, especially with the teenagers. They get into the inhalants. Maybe they're also getting into your spice cabinet as well. When I was looking at the American Poison Control Center information, they had some interesting stuff like don't run your gas-powered electric generator inside the house. And I think that's like in response to the storms that the East Coast has faced and to avoid carbon monoxide poisoning. But one I looked at was about cinnamon. I don't know if you ever heard this. Cinnamon's not psychoactive, but kind of a hazing ritual is to try and ingest a spoonful of cinnamon, and then people end up sort of choking on it because it dries out the mouth and the throat so much. I just thought I'd kind of pass that on. I'd never heard of it. It's like the old Tom and Jerry ads when they give themselves spoons of alum. Huh?
A friend of mine's son had a roommate who, it was a hazing as
Yeah.
part of a, not a sorority,
Fraternity.
Fraternity, and he had asthma as a
Yeah.
predisposing, and ended up in the ER.
Yeah.
because of it.
Yeah, so yeah, it is something that causes probably people with asthma to run into trouble, and maybe others as well. So take the cinnamon, take the nutmeg, take the mace out of your spice cabinet. If you want more information on sort of street drugs, these are some sources that you can go to. All right. So on to recovery medications. Antabuse is a useful medication, but it has to be administered a certain way for it to work. Antabuse, or its generic name disulfiram, is something that you take on a daily basis. There's different dosing schedules, but the easiest one to remember is 250 milligrams daily. What Antabuse does is it inhibits one of the enzymes that breaks down alcohol. And subsequently, if you're on Antabuse and you drink alcohol, a metabolite of alcohol called acetaldehyde builds up in your bloodstream very quickly and makes you wish you hadn't drank. And you end up in the bathroom throwing up, flushed in the face, diaphoretic, feel like you're going to die. Acetaldehyde is probably also one of the chemicals that leads to the alcoholic hangover, though there's probably other substances that lead to that effect. But anyway, usually within a few minutes of drinking at least one alcoholic beverage, people get quite sick. There's no antidote. Once it starts, it runs its course. It could be stressful enough to, someone that they could die from the reaction. So you don't give it to people who are frail or have a history of myocardial infarctions. I would say an age cutoff is no one older than 60, and probably 45 to 60 you should really think about if this is going to be safe if they did drink any alcohol.
In a situation where a wife grounded up and put in her husband's meat
Yes.
for lunch, so every day at lunch, he'd eat it, and he kind of sits his stomach so it wouldn't stop at the bar on the way home.
Okay, there you go. Well, the way it works, though, is rather than not knowing you're on antabuse, by being on antabuse, it gives you the knowledge that you cannot drink because you're on a deterrent. It doesn't handle cravings, but for some people it can really help. You have to know what antabuse looks like, because the best way to give antabuse is to watch someone take it. So you have to know what the tablets look like. Typically, antabuse is a round white tablet with the letters OP and then the numeral 706 on them. This is a 250 milligram tablet. The 500 milligram tablet, which is sometimes used, has antabuse stamped on it, which makes it easy. But some people, because of their addiction, may substitute something else in the pill bottle when they're doing witnessed antabuse, and they're not taking witnessed antabuse when the witnesser thinks that they are. So the witnesser needs to identify the tablet. So it's more of a behavioral therapy. It really doesn't do anything to the brain like the other recovery medications, but it does give the medication, it does give the patient the knowledge that they can't drink alcohol, and that can really help some people, but it's not for everyone. But the only way it works is if someone witnesses it. Just giving someone a prescription to antabuse typically is no better than placebo, and antabuse has been well studied to realize that it's not an effective recovery medication unless there's a witnesser. And the witnesser has to do it right. It's best that they be a medical professional, but if it's like an employer or a spouse, you have to educate them. Tricks are that they'll try and cheek it or dribble it back into the glass. So you got to use clear liquid in a clear glass. Someone has to look in the mouth after the medication has been swallowed to make sure it's not cheeked. And then they have to remain with that person for at least 15 minutes to prevent them from trying to vomit up the medication. Liquid antabuse can be used as well. That can be used like in the clinic. Can't be used at home because it has to be refrigerated. And I've had a couple patients get up in the middle of the night, pour it out, and pour something else that they concocted back into the bottle because their addiction was so strong. So that's why we don't use liquid antabuse at home. There's some adverse effects. You got to warn people. It can be hepatotoxic. About 1 in 50,000 will end up with fulminant liver failure on antabuse. Sometimes antabuse doesn't work that well. They can drink on it, and that's based on their genetic makeup. That might require an increase in the dose if they tell you about how they didn't get that sick after they experimented with alcohol. You got to tell them to stay away from vinegar. Make sure they don't get alcohol into their system inadvertently, usually through liquid or spray medications. All right, acamprosate, also called Campril. This medication is an anti-craving medication for alcoholics. It has a modest benefit at best. It's usually well tolerated and a safe medication. If they do drink alcohol, it does not make them physically ill. You could combine acamprosate with antabuse and have them on 2 medications. It's got this really awkward dose of a 333 milligram tablet to take 2 of them 3 times a day. So if you do your math, it comes up with this sort of odd number that sometimes people don't like. But it has to be taken 3 times a day to work, so compliance is an issue. So a lot of times people just don't take it, and therefore it doesn't work. In terms of side effects, some people will get GI upset, and you just have to warn people about that. They'll get bloating, extra gas, loose stools, and it tends to kind of go away if they can stay on the medication. Usually keep people on it for about 4 months. In terms of patient selection, it's got to be someone who is really motivated to quit. They want to go to treatment. They want to stop drinking. They're not ambivalent. and they want to do something extra to help not drink by taking a medication that helps with cravings. It also helps if their lives are still somewhat intact. They still got a job, maybe the marriage is still intact, things like that. In terms of what type of cravings it helps with, well, it seems to help with people who drink, at least in part, because they're anxious. They use alcohol as their sort of stress coping mechanism. And there's a real tie-in to drinking when they're feeling stressed, which is usually most of the time. But they have to kind of tell you that, yeah, I'm using alcohol because I'm worried, I'm stressed, and that's how I relax, or try to relax. Of course, it may not be working for them. So that's who you select acamprosate for. You wouldn't necessarily give someone who is in love with alcohol, who has very strong subjective feelings for alcohol, acamprosate, who doesn't say, no, I don't use it for anxiety. I drink because I love the effect. I like it. I don't want to give it up. Please don't take it away from me, doctor. The way acamprosate works is that it's an antagonist or a blocker to an excitatory neurotransmitter system in the brain called the NMDA system that seems to get ramped up by continuous alcohol drinking. And it seems to kind of block that excessive activity is the sort of speculated way that acamprosate works. All right, naltrexone. Naltrexone's been around for a while, tablet form mainly, but now we have the injection of naltrexone. The tablets have to be taken every day. Typically, the studies have looked at 50 to 100 milligrams per day, if it's the tablets. The injection is an intramuscular injection that you get in the butt or the gluteal region about once every 4 weeks, which improves, of course, compliance. The problem with the tablets is the compliance is not that great, so they really don't work that well. And probably the reason for that is that naltrexone works best in ambivalent patients, and ambivalent patients don't take medications. So it's best to try and get them on the injection. The problem with the injection is it's expensive, and sometimes there's some barriers to finding someone who can give it to them. The medication's a little bit fussy when you first mix it up, so it has to be a somewhat experienced injector to do it. Though once you get the knack, it's not that challenging anymore. You can use naltrexone not only for alcohol addiction, but also for opiate addiction. It can have some side effects, which you have to warn people about. Nausea, usually the first few days. Headaches, minor headaches, they can treat with Tylenol. They have to be opiate-free for at least 7 days before you start them on naltrexone. So make sure that you ask about that. If any doubt, get a urine drug test. If you are giving it for opiate addiction specifically, they have to have been off all opiates, which would include Suboxone, for at least 7 days. People lose weight on naltrexone. So if they need to lose weight, great. But if they're, on the lean side or there's an eating disorder issue, be careful. I've seen people's BMIs dropped on injectable naltrexone quite significantly. I would not be surprised if they look at this as a weight loss medication at some point. There have been cases of psychiatric side effects, so warn about suicidality, thoughts of suicide, or depressed mood. And the problem with injectable naltrexone, but we all worry about, if you're giving it to someone with an opiate addict, is that since naltrexone blocks their receptors, that they might sit there with enough heroin to try and overcome that blockade and end up successfully coming over the blockade and then killing themselves with a lethal heroin dose. So that has been a concern, and if you look at the literature, there's a lot of reports of these types of cases from Australia who do a fair amount of, they must have a lot of heroin problems in Australia because a lot of articles on methadone, naltrexone, Suboxone come out of Australia. Sometimes people who get the injection can have injection site problems, but generally they tend to be minor, and as long as you warn people about them, it tends not to be an issue. In terms of who you select for naltrexone, if it's the alcoholic, ambivalent patients, this works great. They stop drinking. They really need to have that emotional tie-in to alcohol where they love to drink. When it's time to take the alcohol away, they feel like they're losing, their girlfriend, their lover, whatever. They have that intense sort of tie-in to alcohol. Works best in men, especially where there's been male-to-male genetic transmission of alcoholism. So find out if dad was an alcoholic or dad was a teetotaler, and then look to see if paternal grandfather was alcoholic, or look at the other men in the family, especially even going on to the maternal side as well. A big study out of Russia that just came out. It was published in Lancet. This is using injectable naltrexone now for opiate addicts, a 24-week study with 250 opiate addicts randomized either to injectable naltrexone or a placebo injection. They had 90% abstinent rates in the treatment arm compared to 35% abstinent rates in the placebo arm. Patients were given biweekly counseling sessions. This study did not have any deaths, so that kind of fear I have, what I told you about them trying to overdose, accidentally overdose when they're trying to get over the blockade, did not occur in this study. So this study I think is important. This study makes me want to use Vivitrol more, especially for people with opiate addiction. In terms of how well it can work for alcoholics, there was the days to the first drinks was 3 times greater with the Vivitrol injection as opposed to a placebo injection. The first day to heavy drinking, a heavy drinking day is when they have 6 or more drinks in a day, was 6 times greater, and the number of patients who were totally absent for alcohol was 3 times greater in the treatment. And then if you pooled all the patient data, the overall drinking days and heavy drinking days were 90% lower in the treatment arm compared to the placebo arm. And this is a study from Stephanie O'Malley in 2007, and she was one of the researchers who first started looking at naltrexone in its oral form for alcoholics back in the early 90s. Okay, we're running low on time, so I'm going to talk about buprenorphine. This is Suboxone. Buprenorphine is indicated for patients with opiate addiction. It's a partial opiate agonist, so remember how I was talking about cannabinoids and synthetic cannabinoids. A partial opiate agonist gets on the receptor but does not switch the receptor on fully. It only switches on the receptor partially. So the benefit for the patient is that you treat the withdrawal state with buprenorphine. They're no longer in withdrawal, but since the receptor does not get turned on all the way, they don't get high. And since buprenorphine has a very strong affinity for opiate receptors, it's very hard to displace it should they try and use an opiate like heroin. So buprenorphine turns out to be a very safe medication. You don't see overdose deaths typically on patients who are on buprenorphine. And the additional good thing about buprenorphine is it has this ceiling effect. So it's not like the patients can really get intoxicated on it. Once you get to about 16 to 32 milligrams once a day, the effect of the medication starts to plateau off. So with heroin, you just keep going up and up and up until you die. With buprenorphine, you plateau off and you don't get any additional effect, and that's what makes it safe. It's a fussy medication to get into the body. They've got to put it under the tongue and let it dissolve. If you do want to get high from buprenorphine, though, the best way to do it is to inject it. So they designed the tablets and also now these medicinal films that we have, and they put Narcan in there, also called naloxone. And the reason they do that is if someone did dissolve their film or tablet into a solution and injected, the naloxone would be the effect that they get. So it would be like they're injecting themselves with Narcan. And if someone does that who's opiate tolerant, it's going to throw them into an immediate withdrawal. And you explain that to patients so that they understand why it's in there. So this is just an example of the kind of partial versus full opiate at the mu receptors. And you kind of see that plateau with the buprenorphine, though. Even if you increase the dose, you don't get any additional opiate effect, as opposed to a full agonist opiate. For here it's saying methadone, but pretty much all of them are full agonists that we think of: heroin, morphine, oxycodone. This is what the films look like. The films came out a few years ago and replaced the tablets. One reason they came out with the films is that they seem to be able to put them in these wrappers easier, and this helps prevent toddler poisonings. A lot of kids were getting into mom and dad's Suboxone, probably because it looked like candy because of the orange color, and they saw mom and dad put it in their mouth and maybe thought they were sucking on it like candy. So it's really hard to get into these wrappers. I've tried it myself, and I ended up having to use scissors. But they put this film under the tongue, press it down with their tongue, and in the space behind their lower teeth, and let it dissolve. And it takes typically a few seconds. The tablets could sometimes take a few minutes. In terms of the effects of IV heroin without buprenorphine, what happens is there's 3 zones that the opiate addict's going to be in. They're either going to be in the red zone, which means they're in withdrawal. Normal, meaning their opiate receptors are still full enough that they're not in withdrawal, but they're not high. And then that purple zone at the top where they've got enough receptors full, but they're high. Heroin has a very quick onset of effect. It crosses the blood-brain barrier very effectively, where it's converted actually into morphine, and morphine is actually the psychoactive drug. Heroin's actually just a prodrug, but it gets across the blood-brain barrier better than morphine on its own. And they get high, and they have to do this 2, 3, 4 times a day, typically, to stave off withdrawal. After a while, their tolerance gets so high, you can think of that purple zone going higher and higher and higher, but they're not getting high anymore. They're just trying to stay normal or prevent withdrawal. If you use buprenorphine and then someone uses heroin on top of that, since buprenorphine has such a strong affinity for the receptors, it makes it very hard for the heroin to attach to the receptors and cause the effect. So generally, patients are not going to get high when they do use heroin, and then this is why it's safe. This may not happen as much with naltrexone, where they might keep trying to use and subsequently overdose. The big study that got us all on board with Suboxone, it came out in 2003, about the same time that Suboxone became available in this country to be prescribed. And this is a study out of Sweden, and I don't know how to pronounce that name, but I think it's a Swedish or Finnish name. But the big thing about the treatment group who got Suboxone, and this is a year-long study, is that 75% stayed in the study, and negative urine drug test overall, the drug test overall was 75% negative. So the placebo group, 20% of them died. No one died in the treatment group. So this kind of reinforces, one of the reasons you want to give people Suboxone is that injecting drug use is highly dangerous. And the chances of someone dying who injects on a regular basis is, if you compare them to a non-injector at the same age, the injector has about a 30 times likelihood of dying compared to the non-injector. And, and death could be due to overdose, accidental death, violent death, death from consequences of medical problems from injecting. Subsequent studies have supported Suboxone. The thing about Suboxone is that they may still use from time to time, and a lot of proponents of Suboxone will say this is harm reduction. They're not using as much, they're less likely to die. Hopefully with treatment they'll move away from use. I think the problem for us in treatment is we're really wanting the patients to turn their life around and move away from a life of addiction and improve their recovery environments and not use. So we kind of need to get that message into our patients, that this is a tool to help them not to use, but let's do the other things that you'll learn in treatment so that you improve your circumstances. Okay, that's the end.
Oh,
Yeah.
I was just in Hawaii, and we were driving by lots of stuff, but we seen a store that had band salts.
Yes.
And then we drove by a paraphernalia shop. It was
Yes.
a big, big side of the building, and it had all the, the tobacco smoking things.
Yeah, the bongs, the water pipes,
Yeah.
hookahs.
Yeah, hookahs.
Mhm.
And then they had, said some other things they were advertising, and they had medical detox. So I don't know if you heard of that, but I was like, what?
You mean you could?
So they're selling kind of detox drugs.
Yeah, there's a drug. I can never. It's ibogaine. Can anyone help me? Ibogaine. Ibogaine is a substance you can probably buy in head shops. It comes from a plant from Africa. People on the internet will say how wonderful it is for detoxifying you from any substance. Not only will you be detoxified, but you won't even want to use anymore. So it's a miracle drug, therefore it's snake oil. But ibogaine is sometimes sold. Yeah. All right. Yeah, Bill.
Comment on the use potential of Suboxone. I hear kids every so often are using it or even seeking it out. And I've heard of at least one case where somebody's actually died of supposed Suboxone.
Suboxone's pretty safe. The people who run into trouble are those who are naive to opiates. So these would be toddler children poisonings, or people who are just seeing if they can get high from it but not used to opiates and may take too much, like they might take any too much of opiates. The main concern with Suboxone prescriptions is diversion, is that they sell it. And the main concern there is that if the DEA recommends to the FDA that Suboxone is more abusable than its current scheduling indicates, it's a Schedule 3, and they raise it to a Schedule 2, then we will no longer be able to use it for office-based opiate agonist treatment. So that's our concern. Diverted Suboxone, well, the thing to do is not to give them too much. Remember how I told you about the plateau effect? If they're requesting doses higher than 16 milligrams per day, there's a good chance that they're probably diverting it. And they may be diverting even if they're on a lower dose. Sometimes doing film or tablet counts can kind of help get around that.
We had a lot of parents that are on it, and their kids, like a family, I don't know exactly about, but we have a lot of these patients.
Yeah, and it's just, some of these like opiate naive relatively, they're a young adolescent, they start using it, could they in theory get high?
Yes, they might be able to get high. Any questions from Economowalk?
Economowalk?
Yeah, this is Pat Hammer. I had a question in regards to the injectable form of naltrexone versus the tablet dose.
Yes.
And a lot of research shown that there's a 90% reduction effect on heavy drinking. What's your opinion on the tablet dose versus the injectable?
The tablet has the advantage of cost. It costs a lot less. It's probably going to be about $100 per month. If there are problems with side effects, well, you can stop the medication or reduce the dose fairly quickly. Other advantages of naltrexone is that there are circumstances where patients do need opiates because they're in pain. If you're anticipating like a surgery in a week or so, then you can stop the naltrexone ahead of time if it's in tablet form. With the injection, you would have to try and plan the elective surgery around the injection times, which is a little less convenient. Hands down, though, the injection seems to work better. Patients just do not take their naltrexone tablets like they need to. Maybe 15 to 20% take it right. And when I was in practice at my previous job, what's fascinating about Vivitrol is people come back for their injections, and you don't get high from it. You get a painful injection in the butt. Why are you coming back for it? So it's doing something positive for them. Naltrexone tablets, things almost always kind of fizzled after about maybe 2 months at best. People kind of drop off. I do prescribe naltrexone tablets, and you can prescribe them in anticipation of them going on Vivitrol, but they can't start the Vivitrol until they get all their ducks in a row.
Do you think the blood levels stay equal if they take the tablet on a regular basis as the injection?
Yeah, what's interesting about the injection is it seems to be comparable to about a 25 milligram a day tablet dose. Though in the tablet studies, there seemed to be a benefit for trying to push the dose higher. 50 milligrams was better than, 100 milligrams was better than 50 milligrams. And some addictionists will push people up even higher beyond 100 milligrams a day if they are in fact taking their tablets. The people who are going to be most compliant with oral naltrexone are usually going to be health professionals or other professionals with opiate addiction who are under some sort of monitoring where their professional license is going to be taken away if they're not compliant with naltrexone. So a lot of times on health professional urine drug test panels, naltrexone will be on there to see if they're compliant with their naltrexone tablets. Any other questions? All right, wrap it up. Thank you.
Other questions? Thank you. Thank you, everyone.
Yeah, thanks for coming. So it's the functionality. You know, addiction is out of control use, where your priorities are obtaining and using the substance, and everything else is secondary to that. While with Suboxone, as long as you take it every day, you're going to be fine.